1 in 3 patients on antidepressants achieves full remission, but 1 in 4 patients on a sugar pill also achieve full remission. That's the gap. Now listen, this is not my opinion. That's the largest meta-analysis we have. 131 placebo-controlled trials, 27,000 patients. The drug arm outperformed the placebo arm by less than 2 points on a 50-point depression scale. That was actually below the threshold the researchers set for themselves to determine clinical significance. So listen, if you've been on Lexapro, Zoloft, Prozac, Wellbutrin, Effexor for years, and you've noticed that they're not doing what they used to, you're not crazy and you're not weak. There's a mechanism, there's a name, and there's a path. I'm Dr. Dee Bonney, and our office has treated over 800 patients with treatment-resistant depression in my IV Ketamine therapy clinic in central Indiana. In the next 10 minutes, I'm going to walk you through 3 things. 1, what an SSRI actually does inside your brain. Number 2, why your brain stops responding to it even when it worked for years. And then 3, what works when SSRIs actually don't. You see, the patients who walked into my office have on average tried 4 different antidepressants before they ever heard about what we do, this therapy that we offer. And some have tried 8 meds, some actually have tried 12. And I'll tell you the 2 most common phrases that I hear almost verbatim in the initial consultations. One of those is, none of the meds I've tried have ever really helped me the way that I needed them to. Or they worked for a little while, but then they just stopped. I've heard that last line or some version of that probably more than 800 times. Now here's the part of the story that almost never makes it into a doctor's appointment. So in that meta-analysis that I mentioned, 27,000 patients were included, 131 separate trials. 35% of the patients on an SSRI reached full remission, but 25% of the patients in the placebo, the sugar pill group, also reached full remission. So both groups got better, both. And in fact, on the depression rating scale itself, the drug arm, the SSRI group, dropped about 2 points further than the placebo arm. That's less than 2 points on a 50-point scale. So the researchers, and they're not anti-medication people, these are statisticians and clinicians. They set their own threshold for clinical significance at 3 points. So the actual gap in improvement fell below their own bar. And here's what nobody actually tells you. The median antidepressant trial, it lasts for about 8 weeks. So 88% of all the SSRI trials end in 12 weeks or less. Almost none of them follow patients beyond a year. And the median real-world use of antidepressants in this country, it's 5 years. So 30 times longer than the trials that we use to approve the medicines. And when researchers follow patients past 12 weeks, past 6 months, the drug-placebo gap, it essentially vanishes. So here's what this means. If it's below statistical significance, that means that the medicine stops separating it off from the sugar pill. So now, here's the important part. SSRIs can work for some people, and sometimes they work really well. Probably for that 1 in 3 in the trial data. Yeah, they worked pretty well for them. The question isn't whether they work for anyone. The question is this. If they worked for you and then they stopped, why did they stop working? And that's what the rest of this video is going to cover. You see, I'm going to give you a 4-minute neuroscience lesson on what an SSRI actually does inside your brain. Because once you see the mechanism, you'll stop blaming yourself. This is a synapse. It's an area between 2 neurons. It's the gap between them. So every thought, every feeling, every regulation of mood you experience, all of that happens in a synapse like this. So the communication happens across this gap through chemical messengers we call neurotransmitters. And the most famous neurotransmitter is the one that SSRIs target, serotonin. So here's what's supposed to happen. Your presynaptic neuron, so before the gap, the presynaptic neuron releases this and it crosses the gap. And so it binds to these postsynaptic neuron receptors. That's the receiving side. So then the receptors fire, the signal moves on, mood, sleep, anxiety get regulated if they're working. So what happens with this extra serotonin that's left is it gets taken back up into this presynaptic neuron by this transporter. So after it's done its job there in that gap, this presynaptic neuron takes it back up through this transporter. That's recycling, it's efficient, like that's normal, that's what should happen. But this right here, this transporter, that's where SSRIs work. So they block that reuptake. That's why it stands for selective serotonin reuptake inhibitor. So that phrase tells you exactly what it does. It blocks the reuptake So the serotonin actually sits in that gap longer. There's more of a signal. That means that there's more activation of this receptor. Better mood, better sleep, less anxiety. That's the magic. That's what's supposed to happen in theory when they work. But here's what nobody told you. When you flood the synapse with extra serotonin because you're blocking the reuptake, for years, the receiving neuron does something predictable. So something that this field has known about for decades. It starts pulling receptors off the surface. So you have initially all of these receptors here, and then months to years later, now you have fewer of these receptors. So it almost doesn't sometimes matter that there's extra serotonin in that space. There's actually not enough receptors for it to hit and actually do the job. And that's why the effect tends to wear off. So when you have fewer receptors here, after months or years of this happening, that means that less signal is needed. This is called receptor downregulation. So it's not a side effect. It's not a malfunction. It's basic biology. Like your brain is adapting to the chronic flood of all this extra serotonin. And when it's adapted past a certain point, your SSRIs, they don't have anywhere to deliver their signal. So the medication is doing exactly what it was designed to do. Your brain has just stopped responding to that signal because it's downregulated. So this is called tachyphylaxis. And that's why people say that it stopped working. So it's not your fault. It's not weakness. It's not even necessarily that you're treatment resistant. It's a predictable consequence of long-term receptor occupancy in a system that's designed to adapt. So when your psychiatrist tells you, well, let's increase the dose, they're trying to flood the system here with more serotonin to overcome that downregulation. Sometimes that works for a while, but then the brain downregulates further. So then switching to a different SSRI does the same thing. There's a temporary boost, and then you get this readaptation. So adding a second medication adds a different mechanism on top, which is why augmentation can help, but doesn't really solve the underlying issue. The underlying issue is that the serotonin targeting layer of the brain, it's no longer the layer where all the leverage is. So now what? So you've spent 5 years, 10 years, sometimes 20 years on a medication that worked and then it plateaued. And you've been told, well, just keep climbing the ladder of more medication, thus more side effects, weight gain, loss of libido, emotional flattening. Some people call it just being antidepressant numb. But here's the thing, there's another path, and it doesn't work on the serotonin system at all. It works on a completely different system. This is the glutamate system. It's the most abundant neurotransmitter in your brain. So your prefrontal cortex, that part of your brain that handles the executive function, the focus, the mood regulation, decision-making, planning, it runs primarily on glutamate, not serotonin. And there's a particular receptor on the postsynaptic side called NMDA. So this is glutamate here in the middle. So when glutamate hits this NMDA receptor the right way downstream, this is where it gets very interesting. So the neuron releases a molecule that I want you to remember. This is very important. That molecule is called BDNF, brain-derived neurotropic factor. So I tell my patients to think of it, it's like Miracle-Gro for the brain. So BDNF is what allows your neurons to physically grow new synaptic connections. Not metaphorically, but physically, like we can image this. We call it synaptogenesis, and it happens within hours, not even weeks. And it's the mechanism behind the most promising treatments we have for depression that stopped responding to the traditional medicines. So IV Ketamine at clinical doses that we use in our office is the most well-studied glutamate modulating treatment that we have. So ketamine is an NMDA receptor antagonist, meaning it blocks it, and through this chain of biochemical events that I won't bore you with, but which are well documented in peer-reviewed literature, it triggers that BDNF release. So it restores those synaptic connections in the prefrontal cortex that chronic stress, depression, and trauma have kind of pruned away. So this is not a serotonin medicine. It's not just a mood elevator in the way that SSRIs are. It's a structural intervention. It rebuilds the wiring of the brain regions that depression has caused to shrink. So that is why, in our practice, we measure a 65 to 70% reduction in PHQ-9 and GAD-7 scores within 3 or 4 weeks. So PHQ-9, it's the depression screening questionnaire, and the GAD-7, that's the anxiety one. These are standardized, used everywhere. It's not me grading my own homework. So people come into our office with PHQ-9 scores in the high teens, low 20s. That's severe depression. And then they walk out 3 or 4 weeks later in single digits. Like we've seen it multiple times now. We've treated over 800 people. It's not a miracle. It's just a different mechanism. So I want to be very careful here. It's not a magic pill. It's not for everyone. So if people have certain psychiatric conditions or psychotic disorders, certain medications can impact that. We need to screen carefully. And we do sometimes turn patients away. Not everybody's a candidate. But it's also not a standalone treatment. The patients who do best are doing therapy alongside of it. So this 72-hour neuroplastic window after each infusion, that's when the structural rewiring happens quickest. And therapy in that window, it's enormously more effective than just therapy alone. So it's one tool. It's a good one though, when used correctly. So if you're sitting on year 10 of an SSRI that used to work but now barely does, or your psychiatrist's only suggestion is to switch you to your 5th, 6th medication, please just understand that what you're experiencing has a name, it has a mechanism, and there are paths that actually work differently. So don't think of yourself as treatment resistant. You are receptor downregulated. The serotonin layer is not where the leverage is anymore. The structural layer, though, might be. Now listen, if this seemed to resonate with you, below this in the description, there's a link. Click on that link, come over to our page, and I have a video there where I explain how ketamine works, why it works, who it's for, who it maybe isn't for, and I'll just kind of go through that with you on that page. And then if you feel like that this is something that could help, let me just encourage you to book a free consult with my team. We'll go through what you've tried, what's worked, what hasn't, and then together we can kind of decide if this is a therapy that you qualify for, if it's the next best step for you. Listen, I'm Dr. D, and if you found this useful, and especially if you've been quietly carrying on at that SSRI plateau without anyone actually naming it for you, share this with somebody who needs to hear it. Hit the subscribe button so I can bring you more of these videos. And let's just remember that it's about brain health, not mental health. It's mechanism over willpower. I'm Dr. D. I'll see you at the next video.